Hello everyone and welcome back. In this narrated video presentation, we'll be learning about the evolution of the community health worker through looking at the international and historical context of community health work that's been performed in the past, as well as placing yourselves in the present of community health work today and looking to the future. Let's get started. The earliest known examples of community health workers could be found in Russia as far back as the 1800s. In Russia, these community members called feldshares were trained to provide care for soldiers and other community members where any formal medical treatment was not available. They continue to be an important part of the healthcare system in Russia today and are often the first point of contact for people in rural areas. Probably the most famous historical example of community health workers' beginnings comes in the 1950s when Mao Zedong promoted the concept of community health workers to improve the health of rural communities in China. Doctors sent from cities to rural areas did not want to stay there, so a community health worker approach was implemented so those services could still be available even when the doctors weren't. These people who remained in the communities and were trained were referred to as barefoot doctors because they were often too poor to afford shoes themselves. These village health workers usually received training to treat common illnesses, promote sanitation, and give immunizations, as well as basic first aid. Also, starting in the 1950s back in the US, you started to see the beginning of formal community health work participation in our healthcare system. So rising need because of limited access to advanced care, increasing costs of healthcare, and reduced communication between providers and patients. Community health workers were hired to bridge the community to the healthcare delivery system as it continued to grow. The 1960s saw community health workers expanding not only in healthcare, but also in promoting civil and social advocacy. The Black Panther Party advocated for the government to provide free healthcare, including preventative healthcare and drug treatment for all oppressed people. They created many programs to support the health and self-determination of their communities, including free breakfast programs for school children and free medical clinics in poor communities of color. People's free medical centers were staffed by volunteers from the communities they served. In 1962, the Federal Migrant Act required migrant clinics to conduct outreach in migrant labor camps. Community health workers were hired to do this outreach, building on the promotora tradition that was common in Mexico and Latin America. Many of the migrant farm workers living in camps were raised or had family ties in Mexico and other parts of Latin America, so this policy change coincided with the surge in community organizing within farm worker communities, including efforts led by Cesar Chavez, Dolores Huerta, and the United Farm Workers organizing for the health and human rights of their communities. Further on in the 1960s, community health workers emerged as part of programs launched by Lyndon B. Johnson with a mission to end poverty, promote equality, improve education, rejuvenate cities, and even protect the environment. By the end of the 1960s, the Indian Health Services started the Community Health Representative Program, or CHR, to promote health in the native communities by training community members to provide accessible and culturally relevant health services. This collaboration with American Indian tribes is one of the oldest and largest in the U.S. CHRs serve more than 250 tribes throughout the U.S. today and work on child and maternal health, diabetes management, and other chronic diseases. In 1978, the World Health Organization adopted the concept of primary health care as a key strategy for achieving what they called health for all by the year 2000. Still working on that, it seems. Central to their strategy, though, was community participation, or using community members and village health workers to identify health problems and their solutions. In the 60s and 70s, community health worker programs continued to develop in the newly independent Tanzania and in Zimbabwe. So by the 1980s, Riders for Health had started to support community health workers in 7 African countries, including Zimbabwe, Zambia, Kenya, Nigeria, Lesotho, Malawi, and the Gambia. In 1987, the AIDS Coalition to Unleash Power formed to organize and advocate for investment in the community health outreach, education, testing, treatment, and access to quality health care for people affected by HIV and AIDS. ACT UP activists built strategic partnerships with health and public health professionals and demanded policy changes and new public health programs to address the AIDS epidemic, including hiring community health workers to conduct outreach, providing client-centered education and counseling, HIV antibody testing, and much more. Now we're really starting to see more of the formal structure in which we see community health work today, which is a continuum of both healthcare services, advocacy, and education. So now that we are looking in the present, there are more than 120,000 community health workers that serve in communities throughout the United States. Many states have community health worker organizations to standardize and promote the role of community health work, and some states have passed legislation that require the use of community health workers. This data continues to evolve as we continue to develop community health worker best practices and continue to receive funding and support for research programs that promote community health work. One of the ways we support that sustainability for community health work and continue to grow in its capacity nationally and at the state level is through associations. In Rhode Island, we have the Community Health Worker Association of Rhode Island, or CHWARI for short. In 2008 was the first community health worker training session in Rhode Island that took place, and it was so overattended that people were turned away due to capacity issues. This led to a second training and an all-day conference sponsored by members of the original planning committee. CHWARI in 2009 saw the planning committee beginning to meet regularly to organize other training sessions, where the Department of Labor and Training began to formally support the association through its reinforcement of the need for a large and growing community health workforce in Rhode Island. This planning committee also began to review other states' core competency training programs and offerings towards developing a program of its own, which, over time, has evolved into the very training you're sitting in today. The other essential way that we promote community health work sustainability is through certification. What certification allows us to do is set a benchmark for the core skills and competencies that we want all community health workers to possess, regardless of what their position or role. This allows organizations and the community health workers themselves to feel confident that they have what it takes to really influence positive change in the communities they serve. That's why we focus so much on ensuring that you're able to submit your application for Certified Community Health Worker by the end of this training. We really invite you and welcome you and want you to join our professional community as soon as you're ready.